afternoon and welcome to AHCC Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. AHCC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for AHCC, and I'm happy to be hosting today's program. This afternoon, we're going to be discussing some tricky coding scenarios. And I'd like to introduce our industry guest for this episode. Today, we have AHCC Advisory Board member Celeste Miller, and we have AHCC Advisory Board Vice Chair Apryl Swafford on the call today. Thanks so much for joining us, ladies.
Thank you.
Thanks for having us.
All right, before we get started, I want to just let listeners know if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of those questions as we can. And I know we've got lots of good scenarios to talk about today. So Celeste, I'm just going to turn things over to you and just let me know when to advance to the next slide. There is a little bit of a lag when I advance, so just know that it takes a second or two to catch up.
Okay, thank you.
Sure.
Well, hello, everybody. Good to speak with you today. We're going to go through some difficult coding scenarios. And one of the areas that a lot of coders struggle with is our COPD section. You know, there was some updates a while ago about how we should code those that were exacerbated, either with pneumonia, a lower respiratory infection. Previous to that, there was different guidance. So we just want to kind of go over this and remind you of the most updated guidance for this. So our scenario one, the patient was admitted to the hospital for a COPD exacerbation, pneumonia due to Klebsiella pneumoniae, central lobular emphysema, and mild persistent asthma with acute exacerbation. The patient has a 30-year history of cigarette smoking and quit 2 years ago. The home health nurse documents that the focus of care is the COPD exacerbation. How would you code this patient? So when we're looking at this, you know, there's multiple different things going on with this patient. We've got pneumonia, we've got emphysema, the COPD is exacerbated, plus, you know, some asthma that's exacerbated. So you really have to look at all of those elements before, you know, we go into that answer. So Jan, you can advance the slide, please. So basically with this, we're going to look at, you know, sorry, I just minimized you. Sorry, I gotta find my thing. So basically with this, you know, the patient, you know, was admitted to the hospital with a COPD exacerbation. In the scenario, it talks specifically about the COPD exacerbation as the focus of care. Because with these, you know, if the pneumonia was the focus of care, then we would code this differently. So you just kind of have to keep that in mind. There is an option to be able to, you know, sequence this differently based on the scenario. So we would code our COPD exacerbation first because that's the focus of care. And then this patient has a specific type of COPD. So our centrobobular emphysema. So we're going to code that secondary. And then we've also got the pneumonia. So we're going to code our chronic obstructive pulmonary disease with acute lower respiratory infection. And then we're going to code our type of pneumonia, which remember with that, you know, they're combination codes. So you don't have to do the pneumonia unspecified plus the bacterial causative agent. So remember their combinations. And then our mild persistent asthma with acute exacerbation, and then, you know, the personal history of nicotine dependence. Can advance. So our second scenario, the patient was admitted to the hospital and diagnosed with MRSA sepsis related to a UTI. The hospital visit notes for the provider document severe sepsis with acute kidney failure. The patient was hospitalized for 10 days and discharged home with orders for home health. The discharge orders indicate that the acute kidney failure has been resolved prior to the patient discharging home, although the patient does have a history of CKD stage 3B. The patient also has a diagnosis of hypertension. The patient continues at home with IV antibiotics for 20 more days post-hospital discharge. Home health RSN will provide IV administration and PICC dressing changes. The PT will provide interventions to improve patient's mobility and include a fall prevention program. How would you code for this patient? So there's a lot of verbiage in this scenario. So, I always recommend to coders write those things down as you're going through the codes to be able to separate them out, to be able to code things correctly, not miss anything. You can advance the slide. So, with this scenario, the patient was diagnosed with MRSA sepsis related to a UTI. If you read into the documentation, it talks about acute kidney failure, but that is resolved before the patient discharges home, which we know with any type of our organ failure that puts us into severe sepsis. So basically this patient had severe sepsis, but was, discharged home with just regular sepsis because the acute kidney failure was resolved. The patient was hospitalized, for 10 days. So that's quite a long time to be in the hospital. And then they also were discharged home with, those antibiotics, which, really shows us that this patient, had it pretty severe and they're going to be on it for another 20 more days. So that's significant as well. So our first code, sepsis due to the MRSA, A41.02, and then, the UTI goes secondary, so the N39.0. And then this patient had hypertension and chronic kidney disease, so we have that, that code that we have to do with the combination. So our hypertension CKD was stage 1 through stage 4, and then our specific CKD stage, which is the 3B. And then we coded the encounter for adjustment and management of vascular access devices because we're going to be managing the PICC dressing changes and the IV administration for the next 20 days. And then long-term use of antibiotics because this is a rare circumstance. Normally we don't have people on IV antibiotics for 30 days or more. So it is a long-term use. So that kind of explains that scenario. Thank you.
Thanks, Celeste.
You're welcome.
All right, and April, you've got a couple of scenarios for us too.
All right. Do we not all hate code and respiratory scenarios? Those are the worst because they just keep changing the guidance on us. And it's just a toss-up sometimes. Just throw all of them up in the air and see which ones land face up. That's the way I feel some days. All right, let's look at a couple of more complication scenarios because I know those are tough for all of us. And I'll tell you, especially with the sepsis that Celeste just did, when I start to code a sepsis, I have to read every single bit of the guidance. Every single time, no matter how long I've done it or how many of them I do, I have to go through and read the guidance every single time. So if you do that, you're probably in the majority. All right, let's look at mine. We have a 69-year-old male patient with a medical diagnosis of motor vehicle collision with multiple fractures. Patient is a 69-year-old male with a past medical history of hyperlipidemia, type 2 diabetes, and obstructive sleep apnea, who presents to the hospital after a motor vehicle collision. He had a CT of the cervical spine, as well as a chest, abdomen, and pelvis CT that demonstrated a possible fracture of the C6 vertebral body that was later ruled out, and an L1 compression fracture. He has overall mild to no neck pain, but does have low back pain. He did not lose consciousness. He denies headaches, nausea, vomiting, weakness, numbness, tingling, dizziness, or other focal neurological deficits. So how do we want to code this scenario? Well, we know we're going to have some injury codes, right? Because we got that fracture going on. So let's see how we want to code it. Jan? Okay, so now this is what I went with, and if there's any discussion about any of it, somebody pop up and let's talk about it. S32.018D, because he's coming to home care, it's routine aftercare at this point, other fracture of the first lumbar vertebrae, subsequent encounter for fracture with routine healing. Why did we not code the C6 vertebral body fracture? Was it because that was that possible there? Remember, if we have possible, probable, maybe, similar to, consistent with, any of those words, it is not a confirmed diagnosis, so we don't want to throw that in there. Now, you can go back into the clinician or to the provider, depending on what setting you're working in, and say, hey, you know, was this a vertebral fracture of C6 or not? And we found out later on it was ruled out, but if you didn't have that information, you could always go back and confirm, and then, you know, write you a note so it's on the chart and everybody knows who you spoke to, and then you could code it. But as long as it just says possible, we don't want to code it. And then we want to get our comorbidity conditions. So our diabetes, E11.9, our obstructive sleep apnea, G4733, and then our hypolipidemia, E78.5. Now, we said that the patient has some low back pain. Why did we not code that? Well, we didn't code it because we know most likely what's causing that low back pain is that L1 fracture, right? And if you look up the coding on the pain stuff, it will tell you that if you have whatever's causing the pain, then you really don't have to code the pain there. Now, if it also goes on to say that you could use those pain codes to further specify or, you know, flesh out the picture that you're trying to paint. So if I had a patient that had chronic back pain and then they had this acute back pain to this L1 fracture, then I might use some of those pain codes, but because they've got low back pain and they have a new vertebral fracture, I'm not going to code that low back pain code. All right, Jen. I think this next one was a doozy. Oh, wait a minute, Jen, go back. What was my note? I made myself a note. Y'all see, I don't forgot. Go back one more slide, Jen.
Is it showing the one with your notes? Apologies. Let me.
It is. That's
Okay.
fine. And it's what I wanted to see. But I want to go back to my scenario one time.
Oh, sure. Gotcha.
When it says patient had a L1 compression fracture. Now, you can advance now, Jen. L1 compression fracture. This came from an actual chart. When I looked at this chart, they had coded to S32010D, a wedge compression fracture. The physician has to state wedge compression fracture for you to use wedge compression fracture. We can't take compression fracture and assume it's a wedge compression fracture. Now, I'm not an orthopedic nurse. I'll tell you, that's another thing I look up all the time, are pictures of bones, because it's been a long time since nursing school. So unless the physician or provider specifically documents a wedge compression, we're not going to use that code. We're going to use other fracture of the first lumbar vertebrae, just like we did in this scenario. Okay, Jen, that was it. I'm glad I had that note because I've forgotten.
Great. We did get a couple of questions about some of the codes here. So one question was, why is it coded E11.9 and not E11.69?
E11.69 for my what?
I need to look that up. Let's see. So that would be diabetes with other specified complications.
What would be my other specified complication?
Oh, okay. I see what you're asking.
Yeah.
Okay. So, and then someone else says they didn't say the hyperlipidemia was related to the diabetes. So maybe they were assuming that that was related.
Right. Other specified complication, the provider has to connect those two, and you will see a lot of times in documentation where they say hyperlipidemia related to diabetes. But if you look up the diabetes and you look up with hyperlipidemia, and I can't get to my coding clinic right this minute. Let me see. I've got too many screens going and don't know what to do with none of them. But unless it falls up under that with, then the provider's going to have to connect those two so that you have that causation between them. But that was an excellent question because we do see that documented a lot.
Okay, great. And then there was another question about whether why choose E78.5 for the hyperlipidemia, so that's unspecified, versus E78.4, which is other hyperlipidemia.
Because all they gave me was hyperlipidemia, which means it's unspecified. You know, I didn't have, when you use other, it means, let me pull up my code and clinic so that I can talk sensible. Hang on just a minute.
Thanks for checking this on the fly, April.
No, I don't mind one bit. I mean, these are good questions. These are good, legitimate questions, though, and I always like to talk about it because y'all, I promise you, I am wrong all the time. Don't tell my husband I said that, but I am wrong all the time. So it is always good for me to talk about these things because a lot of times I realized that I hadn't been doing it right, or there was some nuance of it that I hadn't thought about. So when I only have hyperlipidemia and I don't have anything else, I'm going to code it to unspecified. Now, if I have a specified type, so if I look under hyperlipidemia in my alpha, I have a combined, a familial, a specified, a mixed. I have a specified, not elsewhere classified. Other would mean it didn't fall into anything else that I have a specific code for, like combined, like familial, like group A, B, C, or D. So if it had, I don't know, if I was combining it, let's say I was combining it maybe with diabetes. At that point, I might want to use a different code. But as long as I just have hyperlipidemia, then I won't have to code it unspecified because that's all I have.
Fair.
I felt like that was a little rampant.
Yeah, no, I think that makes sense. And then we had one more question. Why is the fracture no longer coded as a collapsed vertebra with a compression fracture not otherwise specified?
Because if we look up fracture, and I'm looking it up as we go, y'all, on the fly. This is live and in person. Fracture, traumatic. Let me get down here. I bet I forgot what kind of fracture I had. So I have a lumbar. So I looked up traumatic fracture, vertebra, lumbar, and it was the first, right? L1. And I have burst. I have a burst stable, a burst unstable. I have a specified type, not elsewhere classified. And then I have a wedge compression. And now what was the question? Why did we not call?
Why is it no longer coded as a collapsed vertebra or compression fracture not otherwise specified?
All right, let's look up. All right, I'm looking up collapse. Let me see what, because I try to look at it from all of the words I try to look at. So if I look up collapse and I look up vertebra, or vertebrae is what I usually say because I'm from the South and you know we don't pronounce anything right. I get back to the M codes, which is the collapsed vertebrae, not elsewhere specified, those kind of things. I'm talking about an injury. So I want to code to an injury category, which is going to be those S codes for my fracture.
That makes sense. Thanks, April, and thanks for walking us through that.
And if they don't, if that didn't answer the question for somebody, tell them just to pop something else back in chat. We'll keep looking. It don't bother me.
Perfect. Thank you. So far,
and I tell y'all that extra respiratory orthopedics, especially when they get complicated, are probably another really hard class for me because I'm not an orthopedic nurse. I never have been. So again, I'm having to look up my bones and my joints and all that stuff. So question me on these if you have a question because again, I may not be right.
Thanks, April. It looks like the questions are slowing down on this one, so I'll move us on to the next one. Oh, wait, we did just get one more question, which asked, would it be appropriate to include the Y code for the motor vehicle, for MVC? I'm assuming that's motor vehicle.
Definitely. It is
Yeah.
definitely appropriate to include that. I have a hard time finding what I want in there. So I probably should have put it in here, and I probably meant to put it in here, but then I thought, oh God, I got to hunt through those external cost codes. I'll just mention that they need to be there. But yes, and I usually try to, if I've got something traumatic like this, an MVA or a burn from, from a brush fire or whatever it is, I usually try to include those. Routine stuff, if I have something like that, it's just a little minor something, I don't usually look it up, but on stuff like this with my injury codes, I will usually look up external cost codes on those. So yes, that is very appropriate, and that is a good point.
Great point. Thanks so much. All right, we'll move on to the next scenario.
So this next one was fun. We have a 47-year-old female with a past medical history of bipolar disorder, anxiety. This was hepatitis C after treatment, past medical and surgical history, including an IV drug use, facilious bacteremia, aortic valve endocarditis, extensive spinal infection, L4 to L1, L4 to S1, paravertebral abscess with osteomyelitis and discitis, L4 to S1 SA, a right paraspinal musculoskeletal abscess, status post laminectomy, abscess evacuation, instrumentation of L2 to S1 on 8/2/25, with plans to complete 6 weeks of ampicillin and ceftriaxone, but with patient representing 8/25 with fevers after missing doses at home. So you know what else I'm going to include here? And I probably didn't on this one. I'm going to put some non-compliance, because why are we missing doses of IV antibiotics at home? Being found to have discitis, osteomyelitis of T11 and T12, interosseous abscess extending into T11 vertebral body, discitis and osteomyelitis at T9 and T10, stable large epidural collection. Also found to have severe aortic stenosis on the repeat TTE and underwent CABG and AV repair on 9/17/25. MRI, I can't even talk today, y'all, on 9/25 showed a continued improvement in the spinal infection. She was on ampicillin and ceftriaxone 8/3 to 8/25, 8/29 to 9/26, then given a dose of dalbavancin, that may not be right, on 9/26 and started on augmentin to take indefinitely. So we're going on some prophylactic treatment here. That is a lot of daggum information. And let me tell y'all, when I run into scenarios like this, I've always got me a notebook, because I'm old and I still have to write stuff down. And I just start making notes. And I put, if I have a date, like on some of this was 8/2 and some of it was 9, I put my dates by it. And then that way I can kind of work in reverse and say, okay, what was going on most recent? Is this my primary issue, or does it relate back to something that was going on at some of these later dates? So in this instance, I would have written all of these diagnoses down when they had the osteomyelitis and where it was and all that, to kind of get my brain thinking toward what is my focus and how do I want to code this complicated case. All right, she presented 3/13 with a week of worsening pain around the sternal wound, recent pus-filled lesion around the incision, intermittent fevers, worsening middle and lower back pain, and it was reproduced with palpation, leg weakness with right foot drop, right foot dorsiflexion is weak on exam. She was afebrile, white count of 6, CT showed a 4.8 by 2.2 by 4.3 fluid collection associated with sternal osteomyelitis, which is acute. The TTE without obvious vegetation of the valves. Blood cultures were collected. We still got that A facilius identified, and she was started on cepapim and vancomycin. Of note, patient reports that she's not been taking the augmentin since 10/20/10 of 2025, when an OSH doctor told her to stop it. They're going to continue the IV antibiotics times 6 weeks at home with home health. Impression, and this again came straight from a chart. So these are the physician's impressions. Sternal wound abscess plus osteomyelitis, back pain due to relapsed infection of the spine or hardware, and setting of patient not taking suppressive antibiotics. Wow, this lady got some problems. She's got some back issues. She's got some front issues. I mean, she's basically limited laying side to side because everything else probably hurts too bad to lay on it. But let's see how we would code it. All right, so this is what I did, because remember, they said she's got a sternal abscess and the osteomyelitis. She's got recurrence of that back osteomyelitis, and then because she's been off that augment. Now, I didn't code, before we go over the codes, non-compliance of her medicine because the provider told her not to take it. So that's kind of a toss-up. Do I think you would be wrong if you coded it? Probably not. But in my mind, I just felt like since the provider had told her that, she was following those providers' orders, and it wasn't so much non-compliance. So here we go. I coded T81.42XA because we're keeping it an A. We're doing the IV antibiotics, so it's going to be an A versus a D. Infection following a procedure, deep incisional surgical site, initial encounter. And then we're going to put B95.2 to capture that E. facilis, which is an enterococcus as cause of disease classified elsewhere. Other acute osteomyelitis, other site, M86.18. And it was due to, remember, the infection due to that spine surgery, that whatever she's got in that spine, that internal fixation or devices that they put in there. So T84.63XA. And then I'm going to use my Z45.2 and my Z79.2 to get my venous access device and my antibiotics. Now, I would also code Z5181 if I was collecting lab. Now, I know that's controversial. Some people say, no, that's not what they meant it for. That's the way I learned it. That's the way I've always done it. Do I think the coding police will come get us if we include it or we don't include it? No, I don't think they will. So, you know, you do what your policy tells or how you've always done it. And there may be some other things that you would include in this, but I figured this was complicated enough codes for us to get through this one.
That was a lot. Thanks,
It is a
April.
lot. After I looked at it, I thought, oh, why did I pick this?
Yeah, I was trying to fit everything all onto the slides, and it was a lengthy one. We did get a question on scenario number 4 about sequencing, and the questioner is wondering, why is the M86.18 sequenced ahead of the T84.63XA?
You could reverse them. You could reverse them if you wanted to. Again, I think that's one of those things that it's not a big deal and nobody's going to slap our hand on. Because there's really, I don't know, and you look and see, and you may find some guidance that I didn't see, but I don't know that there's any guidance that says that you have to. So you want to code, you know, according to the patient need for that specific diagnosis. But I don't think it'd be any problem at all if you reverse those.
All right, thank you. Okay, I've not seen any additional questions. So thanks so much, April. And again, thanks, Celeste. And I'm going to move us along to our scenario spotlight. It's lots of scenarios this episode. And first up, we'll talk about the scenario that we had for you to answer in March. And so this was a patient referral was sent to home health agency from community physician Dr. Jones. Intake reviews the face-to-face and notices that NP Sarah Poppleton completed the face-to-face visit, and there's no visit note from Dr. Jones in the past 90 days. Intake reviews the medical practice that Dr. Jones works in and determines that the NP works in collaboration with Dr. Jones. Intake is unsure if they can accept the patient's referral unless they get the patient in to have a visit with Dr. Jones. What is the most recent clarification or guidance regarding the home health face-to-face that would clarify what is allowed in this situation? And we had 4 options. Telehealth is allowed for face-to-face encounters. The face-to-face date must be noted in the certification statement. The face-to-face may be conducted by a different physician or provider in the same practice as the certifying physician provider with firsthand information of the patient, or the physician or allowed provider who completed the face-to-face must be the certifying physician. And the answer for this one is the face-to-face may be conducted by a different physician or provider in the same practice as the certifying physician or provider with firsthand information of the patient. And our April scenario for you is your home health agency completes a recertification OASIS on day 52 of the current certification period due to a scheduling conflict. The assessment is submitted and services continue without interruption. A week later, your agency realizes the assessment was completed outside the allowed recertification window, days 56 to 60. What should the agency do next? A, complete a new recertification OASIS as soon as possible, even if it's late. B, leave the assessment as is since it was submitted. C, edit the assessment date to fall within days 56 to 60 and resubmit. Or D, discharge and readmit the patient to establish a new certification period. And the question is, what is the most recent clarification guidance? Oh, I apologize. I think I left that face-to-face on the slide. So just choose your answer to this and we will reveal the correct answer on our May call. And now it's time for our product spotlight. This month's episode of AHCC Talk is brought to you by the Home Care Leadership Summit happening May 19th through the 21st in Orlando, Florida. Don't miss your chance to join industry leaders, gain actionable insights, and connect with peers, all at a discounted rate. Secure your spot today and make this year's summit your most impactful one yet. To learn more, reserve your spot at the Home Care Leadership Summit. Visit the link in your handouts, and that's decisionhealth.com/HCLS2026. If you're listening to a podcast version of this call, you'll find the handouts, including the link on the AHCC website under Resources, Free Webinars. And now it's time for What's New with AHCC. And we are sharing some updates from the Association of Home Care Coding and Compliance in this segment. If you hold an HCS-D, HCS-H, HCS-O, or HCS-C credential, please take a few minutes to complete the annual AHCC Credential Holders Survey to let us know how AHCC can help you reach your professional goals. And that link is in your handouts and will also be sent one last time in the AHCC e-zine that goes out at the end of this month. So please take that survey to share your thoughts about AHCC with us. And if you are an AHCC member, we have a members educational call coming up on June 24th when we'll be talking about diagnosis coding and the Hospice Hope tool. Watch your email for a link to register. On this call, we will be going over some hospice coding basics, discussing how the HOPE tool and coding intersect, and taking a look at lessons learned from the home health transition to the OASIS instrument and what hospice professionals might want to keep in mind as a result. And all of this will be brought to you by members of the AHCC Education Committee. We hope you enjoyed this episode of AHCC Talk. Thanks again, Apryl and Celeste, for all the great information you shared. And thanks to all of you for tuning in and for sharing your questions and being a part of AHCC Talk. We hope you'll join us again for our May call on the 11th, when Janan Griffin will join us to talk about survey readiness. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find AHCC Talk on your favorite podcast app, or you can also listen to the recording and access the handouts on the AHCC website at ahc.decisionhealth.com. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening, and we'll see you again next month. Take care.